Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're tackling a cardiovascular emergency you need to recognize, which is cardiac tamponade. While this condition is more common in inpatient or emergency settings, as clinicians, we all play a crucial role in recognizing signs early and ensuring rapid intervention. Let's break down what you need to know in a clear and practical way. Let's dive right in. Starting off with some basic pathophysiology, cardiac tamponade occurs when fluid accumulates in the pericardial sac under pressure, compressing the heart, impairing cardiac filling, and reducing stroke volume. This can happen gradually in cases like malignancy or renal failure, or suddenly due to trauma or aortic dissection. The speed of accumulation determines the physiologic importance of the effusion. Because of pericardial stretch, effusions larger than 1,000 milliliters that develop slowly may produce no hemodynamic effects. Conversely, smaller effusions that appear rapidly can cause tamponade due to the curvilinear relationship between the volume of fluid and the intrapericardial pressure. Now, who's at risk? Cardiac tamponade can develop from multiple causes. It occurs more frequently in patients with identifiable causes of pericardial effusion than in patients with idiopathic pericardial disease. Here are some common causes: cancer, especially lung and breast cancer with pericardial metastases; uremic pericarditis, seen in advanced kidney disease; infectious pericarditis, due to viral and bacterial infections, including tuberculosis; connective tissue diseases like lupus; trauma such as blunt or penetrating chest trauma; aortic dissection, if the dissection ruptures into the pericardial space; post-cardiac procedures or catheter-related perforations; and radiation therapy. Regarding clinical presentation, the classic findings are hypotension, muffled heart sounds, and jugular venous distension. This is called Beck's Triad, and is a huge red flag. But this combination of signs is not always present. Other key signs include Pulsus paradoxus, which is a drop in systolic blood pressure of greater than 10 millimeters of mercury during inspiration. This is a direct consequence of ventricular interdependence. Tachycardia may also be present, and this is a compensation for hemodynamic compromise. In some cases, patient may experience dyspnea and chest discomfort. And in severe cases where patient may be in cardiogenic shock, findings may include weak pulses and cool extremities. Now let's move on to the diagnosis. Cardiac tamponade is a clinical diagnosis. It is highly suggested when the following three elements are all present. Number 1 are signs and symptoms and/or EKG findings suggestive of cardiac tamponade. Classic EKG findings to look for are low QRS voltage and electrical alternans, which is not always present, but is believed to be due to the heart swinging within the large effusion. Number 2 is a pericardial effusion identified by cardiac imaging, and this is usually an echocardiogram. And number 3, echocardiographic signs of tamponade, which may include cardiac chamber collapse and respiratory variation in ventricular volumes and transvalvular flow. However, the diagnosis of cardiac tamponade is definitively confirmed only by the hemodynamic and clinical response to pericardial fluid drainage. Moving on to the management, patients with cardiac tamponade require urgent pericardial fluid drainage to alleviate symptoms and prevent hemodynamic collapse. Pericardial fluid is most commonly drained via percutaneous pericardiocentesis. Let's wrap up with a few key takeaways. Number 1, if you see unexplained hypotension with jugular venous distension and muffled heart sounds, think cardiac tamponade. Number 2, Pulsus paradoxus is a key bedside clue. Check the blood pressure drop on inspiration. However, Remember, not all patients with cardiac tamponade have Pulsus paradoxus, and Pulsus paradoxus is not specific for cardiac tamponade. Number 3. Echocardiography is the primary method for demonstrating tamponade, so get one if time permits. And number 4. If your patient is unstable, don't wait. Pericardiocentesis is life-saving. Alright, let's practice some questions. Question 1. A 55-year-old man presents with progressive dyspnea and fatigue. His past medical history includes lung cancer. Vitals are remarkable for tachycardia and hypotension. Physical exam reveals jugular venous distension and muffled heart sounds. His EKG shows electrical alternans. Which of the following is the next best step? Is it A. Start IV fluids and beta blockers? B. Perform emergent pericardiocentesis? C. Obtain a chest x-ray and re-evaluate in 24 hours? Or D. Order a D-dimer to rule out pulmonary embolism? I'll give you a couple of seconds. If you chose B. Perform emergent pericardiocentesis, you are correct. This patient has signs of cardiac tamponade. Pericardiocentesis is the life-saving treatment, relieving pericardial pressure and restoring cardiac output. Question 2. A 40-year-old woman presents with fatigue and shortness of breath. She was recently diagnosed with lupus. On exam, she is tachycardic with a blood pressure of 92/65 millimeters of mercury. Pulsus paradoxus is also noted, and the EKG shows low voltage QRS. Which of the following is the best diagnostic test? Is it A. Chest X-ray, B. Transthoracic echocardiogram, C. B. Natriuretic peptide level, or D. Pulmonary function test? If you chose B. Transthoracic echocardiogram, you are correct. An echo is the gold standard for diagnosing cardiac tamponade. It will show a pericardial effusion and cardiac chamber collapse. Great job! That's it for today's episode on cardiac tamponade, a life-threatening but treatable condition if caught early. If you like this episode, make sure to subscribe so you never miss an episode. Until next time, this is the Pro PA Podcast, where future pros in medicine are made. See you next time.